I'm Dr. Matthew Stern from the University of Pennsylvania. This is Dr. Susan Bressman from Mount Sinai Medical Center. And this is Dr. Alberto Espe from the University of Cincinnati. And this is a Metaflix original, Parkinson's disease.
It may be that Parkinson's is increasing, that there is a little bit of data that this isn't just better diagnosis, but there may be more Parkinson's happening out there.
Okay, I think this is really important. What do you think about this?
Yeah, I think that the studies would suggest that Parkinson's is increasing in prevalence above any other neurodegenerative disease, including Alzheimer's. Certainly Alzheimer's is more prevalent.
So you think that the incidence is changing?
Yeah.
Yes.
Do we have any data to show that?
Yeah.
Yep.
It's interesting, isn't it?
Yeah.
Why?
Yeah, because we used to just say, because we would see more cases, and we
Right.
go, well, maybe we're just better diagnostically.
Right.
But now we see that there's some real data there.
Yeah.
Why?
That was my question. Why?
Parkinson's isn't a disease, and it was one of the things that we, as you've mentioned, Susan, it really is a combination of diseases. And there is no, in many ways, Parkinson's disease, but people with Parkinson's, each of whom express a different form of the disease. In some cases, perhaps it's very, very mild. In some cases, might not be.
You're one of the foremost authorities on genetics of Parkinson's disease. I think it'd be interesting to talk a little bit about Lark Ii, for example, and GBA. What's the deal with that?
So these are, it's relatively new in the world of Parkinson's. If you go back to Lark II, we're talking about the last 15 years of just sort of learning more and more about this mutation.
And just so people understand, what is Lark II?
So it's a gene that encodes this protein that we really are just learning about. I mean, what it's doing in the brain and how possibly a change, some mutation in the gene, some change in the protein coding could affect its activity in some way and what it's doing and lead to what we think of as the pathology of Parkinson's.
What do you tell patients who might have a relative with Parkinson's disease about getting tested?
So I would say 5 years ago, before we had trials focused on these genes, or 4 years ago, people would go, why? Why should I know? What am I going to do with that information? Oh, do I really want to tell my kids? And then they're going to worry. And this, so they didn't feel really motivated. But now we have trials. I mean, we're recruiting people with these genetic abnormalities into clinical trials. And so now it's a different question. Do I want to be in a clinical trial?
Parkinson's doesn't really begin at the time we, at a clinical encounter, recognize certain motor features, but in fact, it may have happened in a way that is still beyond our recognition years, if not decades before.
And I think this is going to change the way we treat Parkinson's disease and define it, frankly. Just think about this for a second. We in neurodegenerative diseases lag behind general medicine, which is all about prevention and early detection, right? Detection,
right.
Prevention. And we need to do this in our business. And when we hear about REM sleep behavior disorder and loss of sense of smell, we are beginning to envision an era, not in the too distant future, where we will begin to diagnose patients before they develop neurologic symptoms and start treatment to delay the onset of neurologic symptoms.
We are already, because people are making the diagnosis earlier. I was talking before about 23andMe and direct-to-consumer genetic testing. So, and kids are doing this. I mean, 20 and 30-year-olds are doing this. They're curious about their ancestry. They want to know about their genetic predispositions. And they're learning that they carry risk variants or genes that predispose someone to develop Parkinson's disease. And there are two, this GBA and Lark II, that are on those panels. So people are coming, or they have family members with Parkinson's who've tested positive for a gene, or just put them at greater risk. So they're paying more attention to the fact that maybe they have REM behavior disorder, or they lost a sense of smell, or they have this chronic constipation. And I actually have a couple of patients who came to me without a definitive motor diagnosis. It was really these non-motor features. And then what do you do with that information? Do you then get let's say, a brain scan that looks at dopamine and says, oh, look, you have this deficiency, it's asymmetric, it's sort of could be early Parkinson's that we're looking at. And then if you find that, what are you going to do about that?
This is disease prevention. And that's what I was talking about earlier, that we have to catch up with it.
Correct.
We in the Parkinson's and neurodegenerative disease world have to catch up with that. And early detection and prevention is our next, our next major advance in our field. And I think we're going to get there.
Yeah.
And I think maybe, certainly in your lifetime, maybe in ours.
Yeah.
I think that we need to understand aging, deprived from our ideas of what we think abnormal aging is. We think abnormal aging ends into something we call Parkinson's, ends into Alzheimer's, ends into other conditions. But perhaps those labels have been problematic to help us truly understand why we're aging in funny ways. And to the point you're making about the genetic contributions, one way to think about it is that GBA and LRRK2 mutations are going to teach us about Parkinson's. But another way to think about it is that those are going to teach us about those kinds of mutations and that kind of abnormal pattern of aging. Whether it leads to something we call Parkinson's or not, that might be a different story. So it kind of depends on how we're going to be looking at this issue.
I'm a little uncomfortable thinking of it as aging. I know what you're getting at, and I think that for dementing disorders, I think it sort of fits a little better. But Parkinson's can occur in such young individuals,
Yes,
and its peak onset is in patients in their mid-50s or 60. Young.
But think about...
I mean, you could say, well, that's premature aging or something to that effect. And maybe it's aging in the sense that the brain's not functioning normally, and so it's aging in some way. But I don't want people to think that Parkinson's in particular is a disease of aging.
So I have the opposite view, because I look at the genetic variants. I'm thinking they were born with it. Why did it take so long to happen?
Right.
So I actually think that we were talking about smell. So when we look at some of these patients, and now we do scans on relatives who have the mutation but don't have Parkinson's, and we can see changes over time. So the question is, what's brewing there that some people go past the threshold and boom, the pathology is happening, and other people, I don't know if it never happens, but it's way delayed. So that gets to what you do to stay healthy. So maybe the opposite of degeneration. In other words, how do you protect the brain, which gets to early treatment or earlier and earlier diagnosis. So let's say you have a family of high hypercholesterolemia or hypertension, right? So right off the bat, you're going to the doctor, you're checking your pressure, they're checking the cholesterol, family history of breast cancer, all the things that you do so you never get it. So you never get a stroke. That goes back to my wanting to get people involved in research. That even if it's not an interventional trial where we are giving a drug, but we're just gathering information, or we're doing imaging, or we're looking at biomarkers, that we still need answers. And that participation is like that altruistic, it's good for everybody with Parkinson's, is also if we talk about exercise, I think that's the other piece, being part of that.
Yeah.
Then we talk about clinical trials that might be appropriate. And even if there's not one today, maybe there'll be one in 6 months or in 12 months. And that's really uplifting, I think, to be part of a trial. If not everybody wants to do it, but those people who do really, I think, feel good about it.
Yeah, for sure. And there's the other good news about that is that there's so many things out there that are currently in clinical trials. So there's a lot of novel approaches to treatment that are out there being tested right now.
Yes.
So I think that's really something that patients need to know. We all come from academic medical centers. What about the rest of the world out there? What about the rest of the patients in this country? When do you recommend that they actually get seen by a specialist or someone who's trained in treating Parkinson's?
I'm biased. I think they should always, from the beginning. I think you have nothing to lose. And sometimes what will happen is our patients come from far away, and there may not be a movement disorder specialist nearby. So we may communicate with their local neurologist, and there may be once or twice a year they come to see me, and in between they see the local neurologist, and we work together as a team. Obviously, if they live within commuting distance, and of course now we use Zoom. So I actually think having expertise in movement disorders and Parkinson's disease is a good thing. And insofar as patients can manage it and get that opinion, even if it's a once a year, doc, what do you think? Am I on the right meds? I think it's good to do.
You agree?
I agree. In the ideal world, really, all patients with Parkinson's should be seen by experts in Parkinson's centers.
But that's not practical.
But it's not practical.
So what are we going to do with, the at least 75% of patients in this country alone that don't have access to specialty treatment?
So I think here's where education to community doctors is so important. Indeed, we can not, with the resources that we have at our disposal, take care of every patient, as you're alluding, Matt. And this is sort of the model, I think, in cities, not in other parts of the population, unfortunately, but cities have academic centers and then, of course, have a number of community physicians around. And you want your community physicians to be as highly educated on Parkinson's as possible so that they can do as much as they can, ideally with other resources and information so that they don't necessarily get the experience that we've seen here. And then those doctors could think of experts in academic centers like we are to then be the next resource the minute a patient is struggling. We don't want to necessarily, or cannot, be able to sort of provide the care to everyone, but we certainly want to provide care to those that are struggling.
Well, that's the education you were talking about. People are going to the internet, and the better the quality of information people can get, the calmer and the more informed they are when they see us, because they have some background and they sort of can anticipate almost what we're going to say, which is great.
Yeah, this right here is the future.
Yeah.
And as I said earlier, not the distant future. This is where we are now.
Yeah.
We all have people that come up to us and say, I have this sleep disorder, I have a loss of sense of smell, I have a relative with Parkinson's disease, do I have it? And we're able to tell them what their risk is.
Yes.
And in short order, we'll be starting these patients on therapy, and at the very least, talking about some of the lifestyle factors that can make a difference.
Yes.
Another element that I think will be interesting along the lines of early diagnosis, earlier than we can recognize it, is technologies. There are now, all of us use our phones and watches, and
Yes.
the information that can be captured and digested
Yes.
from these devices is tremendous at a
Yes.
population level. So that you could conceive a future in which those could be used to generate information on screening large populations for
Yes.
the possibility that Parkinson's could be perhaps becoming apparent at a motor level with the type of subtle changes that are still not visible to the naked eye, but that the pattern in terms of the activity, the mobility,
Yes.
the sleep patterns, et cetera, combined to create that profile of somebody that later on will
Their
go on to
arms swim when they have two hand devices.
Yeah.
So we look for that.
Isn't that fascinating that there is asymmetry in Parkinson's? That's one of the features that we look for in the exam. And what is it about the asymmetry? What is it about one hemisphere of the brain compared to the other that end up...
Makes one more vulnerable to the other.
Right.
Yeah.
There is, in fact, a very large, now very well-established body of literature that talks about the creativity in Parkinson's disease. Where is that coming from? It could well be that there are changes to some of the neurotransmitter systems. We think dopamine, of course, may be important in non-motor networks. And I'm wondering if some of that...
I agree. I think art is a common path that Parkinson's patients take that they thoroughly enjoy. Our exam room hallway is filled with the photography of my Parkinson's patients, including our conference room now. We have some big photographs. And I want to do a fundraiser that our patients really, with all their fabulous photography, and art too, actually, and jewelry.
I haven't seen a patient with the kind of involuntary movements, dyskinesias, that we used to see, in the 80s, where patients were just horribly dyskinetic. I mean, their life was really imperiled by it.
Yes.
We don't see that anymore.
No.
There's now an inhaler for short-term boost delivery. There is an intestinal gel that gives you a long-term steady state, and there's a medication that actually gives a longer term. So those are all options for improving levodopa delivery, right?
Correct. Plus, we have the patch pump trial.
Right.
So we have all different ways to deliver levodopa and to keep that steady blood level and for the brain not to see these pulses, and potentially that will get rid of any dyskinesias you have or lessen
And now,
them,
by the
certainly.
way, there's some other things. There's the apomorphine infusion that's now in development, which has a lot of promise. It's used all over Europe with great
exactly,
success.
exactly.
So there are so many options to treat these things, not to mention the drugs available to us, both new and old, to treat fluctuations. I mean, even just in the last couple of years or even year, we have sulfonamide, so it's very easy to use.
Yes.
We have a new COMT inhibitor, opicapone, coming out.
Yes, exactly.
So there's all these agents that are available to us, and this is probably where you sort of get into the recommendation that patients at that point see a specialist.
Yes, I mean, we are tinkering with so many possibilities and trying to prioritize which approach to take to either prevent dyskinesias, or once we start to see them happening, to decrease them, to make them less likely to get severe. So exactly.
The issue with dyskinesia really is an interesting one, because I think patients understand dyskinesia as a consequence that may be invariable to levodopa. But in fact, one of the things that we've learned from recent studies, particularly the one that you were mentioning, Matt, about infusion studies, now the infusion system with the idea of trying to keep the levodopa levels as stable as possible, is that in fact in that pivotal study, the one that we now use to document the efficacy of levodopa in a gel formulation for continuous delivery, is that the dosage was actually higher in patients and the dyskinesia was lower. So in most situations when you have a drug leading to a consequence, to a side effect, we think the more of the drug, the worse of the consequence. But in fact, this study demonstrated that dyskinesia is not an artifact of the molecule, but of the way which it is administered.
Yeah.
Yes, we have so many different approaches to stages of Parkinson's and where they are in terms of their medication and what's available. It is complex. It really is complex, and especially with the new medications. You're right.
Yeah.
We didn't talk about deep brain stimulation surgery.
Tell us.
So, and in different centers, I think, depending on the surgeon and your relationship, it can be an important go-to treatment. And I think we're using it earlier than we used to. We used to really, really wait till patients were having all kinds of issues and then consider surgery. I think
Just so people understand, deep brain stimulation is in putting an electrode in a part of the brain and hooking it up to a battery that goes in like a pacemaker.
Right, exactly. It really can be remarkably effective. And I think sometimes we don't use it enough, actually. I think patients also have a fear of deep brain stimulation. And this whole, it's sort of having these batteries in and these wires, and it becomes kind of a whole scary enterprise, but it doesn't need to be at all. And when they meet other patients who now are on less medication, in all their medications, so whatever their medication side effects are, may no longer be present, and they don't have to worry about turning off. I think one of the scariest things that when you go off, even if it's only a half an hour a day, when your meds aren't there for you and you become immobile, it can be terrifying. Mm-hmm. And I would say that's probably my biggest reason I end up sending patients for DBS. You'd think it'd be dyskinesias, but we have other ways to deal with dyskinesias.
That's right.
But those offs, and that's where the ambrosia, that's where those rescue meds can be so important. But for those patients that, for some, I went to the theater. I don't go to the theater anymore. Why? Because I'll turn off and I won't be able to leave, and that's terrifying for me. I had one patient, he would go, his most fun thing in the planet was going to the opera. And now he couldn't go to the opera anymore because after sitting for any prolonged period, his meds, as often happens, wouldn't be there for him. He'd turn off, he couldn't get up, he couldn't leave. It was an embarrassment, the whole thing. And DBS, he goes to the opera now.
We're all like bombarded with patients and don't have the room to see everybody that we'd like to see.
Yeah.
So how do we handle that?
Some of it is just spending time with them. You know, the fact that we are comfortable with them, explaining, going through the whole exam, talking to the family, giving them resources, telling them that there's research out there for a cure. I mean, maybe in your lifetime, we will have a true disease-modifying therapy. Even if your course was so, it'll be even less of a progression over time. That's very reassuring. Our role,
Sure.
not only as a diagnostician, but as a support, as an educator, supporting the family, giving them resources, and just spending time with them. They go, Doc, I can't believe you spend so much time with me. And I think that's part of our profession. You know, there's this thing of moving along, seeing patients quickly, and just spending time so they feel not like a pariah, but like they have a condition that we will treat and deal with.
We are sort of on the threshold of being able to slow this thing down, don't you think?
Yeah, for sure.
And that we never run out of strategies for them, that we never run out
Yes.
of opportunities to help.
For sure.